Good afternoon. I would just like to thank you all for coming this afternoon as we get started on our second meeting for Transforming Children's Behavioral Health Policy and Planning Committee, which we will call TCB because that's still a mouthful and it will be. I am Tammy Exum, representative and for the 19th district. And I just have to say, I'm so happy to see all of you this afternoon, either here in person and also online. It's really strangely quiet in here, which is wonderful. It's really, the lights kind of went low, really got quiet. But I really just want to thank you. For me, this is really realizing this opportunity and our commitment to what we were looking at as far as really transforming children's behavioral health. And this is an opportunity for us to come together and to develop and move towards this plan together with people who have been involved for many years and some who are new at this but care about this so much. I would just like to give the opportunity to my co-chairs here to welcome and introduce themselves and make comments, and then we'll get started because we have a robust agenda. So next, Senator Marr.
Thank you. Hi, I'm CC Marr, Senator CC Marr. Sorry, I shouldn't say that. And the thing that I am so struck about, and I'm so delighted that you're all here, is because the more I learn, the more I realize how much I need to learn. And that means that we have a really big task in front of us as we all look to the ways we can work together and really set up a system that works for children in Connecticut in terms of behavioral health. So I look forward to learning with you. I look forward to working with you, and let's get going.
Thank you. Good afternoon, everyone. Claudia Gualtieri, representing Secretary Beckham. I'm chairing this the TCB committee. So excited to be here today. I know we had our first meeting and it was a lot of introductions and just getting our team filled out. What makes today so exciting is it's actually the day that we start to begin to roll up our sleeves and get to the work at hand. So this is what's so exciting to me. I think we have some excellent presentations on terrific new model that we stood up with the UCCs, hearing from our commissioner and team from DCF on the great work that's already been put in place, and learning more about our structure of how we're going to work and be strategic in designing the future of children's behavioral health. So thank you, and agree, let's get to work. That's exciting.
And with that said, we're going to turn over the first part of the meeting to Erica Narakowski and the Tau Youth Justice Institute, with whom we could not do this work. They will talk about the organizational structure, and also to tell you a bit about this QR code so that we don't spend our entire meeting taking attendance, which we could easily do if we went person by person. And then at that point, we'll move forward, and later in the meeting, we will hear from our urgent crisis centers in DCF. Thank you.
Thank you, everybody, and good afternoon. Very exciting and a very hot day. It's nice to be in an air-conditioned room. So as Representative Exum mentioned, we would like to introduce a new process, which is our attendance. This QR code, if you all have your phones, you're able to scan it, depending on the phone that you have, scan it. It will ask you one or two questions about your name and basically track your attendance. You can also, if you don't have it there, you can, it's projected on the screen as well. But our goal is to make this more of an efficient process moving forward. We do have a checks and balance. When you come into the room, my staff will also, as they are handing you the packet of information for your meeting, they are also taking your name and keeping track of your attendance, just in case you have difficulty using the QR code. But I'm going to pause for a second. Any questions, comments, any concerns about the QR code, difficulty logging on? No? Perfect. Good. Thank you. Good. And it worked. All right. And then the next thing I want to do is at the July meeting, I announced that we were in the process of hiring your support team, your administrative support team. And I am so excited, so very excited to have them here today. And I would like to have them take a minute to introduce themselves. Also in your packet, so that we don't go through all the bio information. But in your packet is a handout that has their picture, their name and titles, and a little bit about who they are. But I wanted to give them the floor to introduce themselves. These are the individuals that you will be receiving emails from, phone calls from. They are your point of contact, and they are the ones who are helping us to develop this really neat, efficient ways of doing our work. So very happy to have them here today. So I will give the floor first to Ash.
So as you remove the sheet with all of our pictures and beautifully laid out bios, my name is Aishwarya. I go by Ash. I'm the senior project manager for TCB. My background is in psychology. I've done my undergrad in psychology and worked in intensive care for rural communities in India. And I have my master's in MPH, public health. So my idea is to incorporate the understanding of psychology into public health practice. So you'll be seeing a lot of emails from my end. Yes.
Hi, good afternoon, everyone. My name is Israeli Mendiera. I am the project coordinator for the TCB committee. I come with 9 years of direct service. I was a case manager in New Haven for children who were detained at the immigration border. I also serve for any child with a chronic medical condition. Along with that, I also advocated for the DREAM Act. Thank you.
Hi, everybody. My name is Shelby Henderson Griffiths. I'm new to the Toll Youth Justice Institute, and I'm the policy administrator. So I'm extremely happy to be here with you all. My experience is mostly in policy, also a law student, and like many of you, I'm a stepmom, a sister, an aunt. So I'm excited to be here and excited to do good work.
Rep Walker, Shelby will also be joining JJPOC work. Thought I'd tie that together. Thank you so much. I want to give the opportunity for Karen, who is one of your consultant as well, and will be providing technical assistance and helping to lead this work. Karen?
Well, good morning, good afternoon, everyone. I thought I was retiring, and I don't know what happened, but I had been up in Massachusetts working for many years, maybe 13 years, and came back and got resettled. I never left Connecticut. I kept my home. I paid my taxes. I did all those things. So I still belong to Connecticut, and came back and thought, oh, this is kind of boring, not having anything like challenging to do, and met up with Erica and decided that this would be really a great project because both my previous work in Connecticut and my experience now in Massachusetts and working so closely with families just gave me the experience of how much families want to be a family, how much they love their kids, how many strengths they have. And if you have a strength-based, available, quality kind of mental health system, your families will just so much appreciate that. One that's welcoming and accepting and non-judgmental and, you know, all those good things that we all thrive when we're with people like that. So I had this chance to join, and I hope I'll be useful, and we'll all get to know one another. And I look forward to doing whatever work I can be helpful with. So I'm glad to be here. Thank you.
Thank you. That concludes the introduction of our team. We look forward to working with you. I would like to give the floor back to the chair so they can do an administrative task of acceptance of the minutes for July.
Thank you so much. And I just have to say, I am so excited by this team to have your organizational support. And I think we're in really good hands. So looking at the acceptance for July meeting minutes, can I get acceptance from? Okay, so move. Okay, second. Are there any, first I want to ask, were there any revisions or suggestions to those meeting minutes? Okay. Well, properly, did you get that? Who's second, first and second? Thank you so much. So at this point, I'm going to turn this back over so we can go through our organizational structure piece.
And I want to also acknowledge that we have some members who are attending virtually. The way, and just want to remind for those individuals who are on Zoom, please to remain muted raise your hand when needing to ask a question. You can also enter feedback and questions onto the chat. My team will periodically review the chat feature on Zoom and make sure that you are called upon. So just wanted to give that quick housekeeping. Okay. So for the meeting today, the first part of the meeting is going to be myself and my team presenting on how we intend to operationalize this work for you all. And then the second part of the meeting is the Department of Children and Families plus the Urgent Crisis Centers will be doing a presentation and an update on the implementation of their programs and services. So first thing first, hearing a lot from me. So here we are. So how, the way in which we would like to operationalize your work and some of what you can expect from us, okay? So some administrative tasks first. You will always be, we will, as I mentioned earlier, we have a team and myself who will be your point of contacts. We will be sending out on a regular basis emails for whether it be questions, feedback, whatever may be that we may need from you all. Our goal is to help you coordinate this work. Our goal is also to draft up reports that may be applicable to or partner with others to draft up reports that may be applicable to this committee. And to provide you with agendas, meeting summaries, meeting minutes, whatever term you want to use, and to be able to provide you a space where you can find all that information. And that would be currently in the sense of communications. Our Tao Youth Justice Institute website is devoting a page to this committee, and we will be uploading all of our documents there. So that is in process and should be, I hope to be able to release that by the October meeting. You can also find a lot of the materials for this committee at the Connecticut General Assembly website for specifically to the link there. We work with Taylor on a regular basis to upload all the materials, meeting minutes, materials that was passed out. Everything that you received today will also be uploaded on the Connecticut General Assembly website. Okay. Other things that you can expect from me, as I mentioned, is once you all make decisions or once decisions are made about how we are operationalizing ourselves, you will get meeting schedules, you will get, like I said, agendas. And if you are scheduled to present, or if any entity or individual is scheduled to present for this committee, we typically do schedule planning meetings. And those planning meetings is to talk about the who, the what, the when, all those type of details that to make sure that we have a successful and productive monthly meeting. Okay, so those are all the things that you may be hearing or receiving from us via email or other forms of communication. Okay. All right. Okay.
In your booklet, there will be a 3-pager list which detailedly explains about the Bill Act 2390. So what we've done is looked into the bill. Thank you. So what we've done is we've looked into the bill in greater detail to understand what our goals look like. So we've also identified few suggested work groups over here, which could lead that program. So to just walk you through it, if you see on the example 1, that is section 12137, it says to establish this committee, and we've already done that. To have our very first meeting, which happened in last July. And this is the second meeting. So that is one thing that we've checked off the 2390. Similarly, in G1, in section 2, the one that is screened up on the screen, it shows that we have to form work groups. Now that is where the main work is going to happen, where we come and collectively form the work groups. So if you look into the bill, you'll see certain works that could be dedicated to either strategic plan, prevention, school-based work groups. Now, these are few that we have identified. But as a committee, we can come along and identify more work groups to make sure that the work gets implemented. So these are few examples. And another one is the annual work plan that we have to present in December. So the dates are coming near. So we have a list of proposed recommendation that we have to give out in December. So that is something that is mentioned in 2390. We've identified all those things as goals so that it is always tied to the legislation while we continue the work. So this is one example. You can look into 2390. It's attached in your folder and have a clear picture of how each section looks like, what could be the group, and who would be the planning authority or the responsible agency behind it. Thank you.
So we want to, thank you, Ash. We want to take this second. There is a pack of copy of the table that is also on the link. The link should open for you when you do it electronically. But we wanted to make sure that we convey that the work that your committee is charged with, we are making sure that we are going back to what the statute says. We are tying everything back to the statute. When we get to the further into the presentation, you'll see that we are very much aware that there are other task force. There's other entities that are doing similar work to you all, and that we need to be very much in line and or getting information from them or updates from them as well. So we'll, as we go further into the presentation, we'll talk about how we're linking that piece of work together to your specific statute. And so this table here is just a starting point. This is very much a draft. We'll talk in more detail about how we want to engage you all in really completing the details and the next steps to it. Okay.
Okay. So as we are all aware, there are certain bills that have already passed. So we created a tool for us to be able to keep track of the existing bills and also task groups that have already begun some of this work. So with this, we want to be able to make data-driven decisions of what is already being done in Connecticut, and also identify contacts that we can reach out and talk about what are our next steps. And this is the part where we would like to invite you as committee members to be able to give us your input on who we should contact, any publications that may be of our interest, and how we can collaborate with you all to be able to make those decisions and those suggested work groups as well. So with this, we are keeping track of common publications and anything that later we wish to use during when we create those work groups to keep us in order.
So this really is us making sure that we are in sort of being informed, because there are other committees that are taking place. Some of you are members to those other committees. Those committees have been charged to similar tasks that we are you may be charged as well. And so in order to reduce duplication of work, this is an opportunity for us to be connecting the dots and maybe asking the question, how do we support those other committees to get some of their work through the finish line?
If I may, through you, so are you then suggesting that we will be a coordinating function for the work of the other committees, or it's just connecting the dots so that we understand where we fit?
That is correct. We are not necessarily coordinating other committees, but it's more that if that committee, say a certain committee is charged with doing a specific, I'll just give an example of workforce development. Your statute, that formed this committee also talks about workforce development. And so to reduce the duplicate efforts, we should be talking to that other committee. We should be getting an update from them. We should be hearing about maybe some of the strengths that they found and some of the barriers or gaps that they had, and then maybe asking the question, so how can we continue to support you in areas that we're not duplicating? So because we both may have a similar charge. So it's not that we're doing any administrative functions for them. So the next page talks about, what Israeli just pulled up is the actual, the link to the spreadsheet, which provides the list of all the existing bills, or many, I shouldn't say all, many of the existing bills that speak to children's behavioral health and some of their specific tasks and responsible parties. And this will be sort of a map for us to who do we tap to, who do we talk to, what should we be aware of. We have another tab for existing task force or other committees that are vital to this work as well. And again, it's in effort to reduce duplicate efforts. Other system partners that we and Karen and I and our team should be talking to. This is just a starting point. We know that there are many other people here that we should be filling in, and this is just the starting point, because again, you all are going to help us fill this in. And then in acronyms, because we did hear from many people asking, what does that stand for? So this is just for a nice little resource tool for you. I'm sure we're missing many more, and we'll be asking you to help us fill in the blanks as well. The next slide that you will see in the PowerPoint speaks to how we want to organize this work. This is an organizational chart that has the committee at the top. And then currently we're proposing 5 work groups. One of them has a dotted line. And the reason that that has a dotted line is that that's the strategic planning. You do have, per the statute, that by December of this year, you have to develop a strategic plan. And so our thinking was that a small group will come together, volunteers, to be the main entity to develop that strategic plan, bring it back to this committee for review and for feedback, and finalize. There would be a vetting process back and forth and ongoing communication. And the reason it's a dotted line is because once that strategic plan is approved by you all are the entity that ensures that this committee is meeting the strategic plan, that the goals that you all set forth are, you're in line, you're in sort of in the trajectory of achieving those goals. Okay. And then based on the statute, what we did is that we created 4 categories: the prevention, services, school-based, system infrastructure. And those would be the main work groups where we will have specific tasks as identified by the Public Act that would fall under those groups. For a description of those work groups, there is a handout in your packet that, again, it's a draft. It's a handout that provides a description of the work groups. And we are looking to engage you all in the next couple of weeks to further define those descriptions. Okay. Each work group most likely will have a subgroup, because we know that a work group is probably going to comprise about significant amount of people, and sometimes it may make sense that we may need to divide and conquer, right? So we may need to assign specific tasks to a smaller subgroup where they will meet on a regular basis, review best practices, review the data, have the conversations, develop the recommendations for how to improve the system, and bring it back to the work group. The work group would then bring it back to this committee for, again, for further feedback. And then okay, so what I just described there, that flow of consensus building, or the flow of the work, is the slide that you're seeing now, where certain tasks, as I said, are assigned to the subgroup, then up to the work group, and then back up here to your committee. What those assignments are, that is what we hope to engage you in the next couple of weeks, based on the statute. Okay. Now, the next slide here really focuses on the overall tentative timeline. I am very much aware that this committee wants some legislative action. And so with that, we sort of wanted to give you a big picture of the flow of the work. Now, we're starting in the odd space because we are in, in September, but I think, and you all do have quite a bit of work to do between now and December. I foresee that we will have a legislative package to deliver. It's just let's see how much of the work we can get done. But this is sort of the flow that we're proposing if we were in a typical year. And the next slide looks at, as was mentioned earlier by Israeli and Ash, we taking step by steps. We've gathered, we've created this committee. We are starting to meet. We're starting to draft agendas. We would like to begin to convene work groups sometime in October. You all will have an opportunity to volunteer to be part of a work group and or a co-chair of the work group as well. We'll talk more about that. Those work groups, it is our hope that in November and October, those work groups will begin to convene and begin to really dive into the tasks that they are assigned to, whether it be reviewing of best practices, whether it be reviewing of data, whether it's developing a plan for a specific area of focus. And one specific area that we know we need to bring to you all is in December is the strategic plan. So we'll talk more about that. This next slide is taking what was presented by Ash earlier, which is the table that has the legislation, excuse me, that has specific tasks assigned in the legislation and basically saying, okay, what does it look like? Meaning like, what specific tasks do we have due by when? And as you can see, the majority of your work is due by December 1st, 2023. And so some of the reality conversation to have, some of the real talk to have is, how many of these things will we be able to do by December? And maybe some of the discussion, this is just, more to come, but maybe some of the discussion is, are there certain things here that we need to prioritize, as I hear many of you say, of create these buckets and prioritize them. And some of them, not that we're leaving behind, but maybe we say we need more time. We may need to adjust the specific deadlines. There is 2 pages full of specific tasks that you all have by December 1st of 2023.
And if I could just interrupt for one moment, when looking at that timeline and going back in time when this legislation came out last year, we were looking at the fact that we had ARPA dollars. I mean, we didn't know what this would look like, but we wanted to jump in quickly. And as you know, this has rolled out a little bit later, but I think the information here is really important. The timelines, though, will be something that we need to adjust, but it certainly is really important to look at each of those areas. But that is why I just wanted to explain, that is why the December 2023 timeline is there. Thank you.
And I also would like to say, again, this is, as I mentioned earlier about connecting the dots, some of these items on here may be already in the works by other committees. We just don't know that. And so, or other entities have already started that work. And so I think it's a matter of Karen and I getting some information about where is it at, what's the status of it? And then maybe that's where we can come back with some suggestions about adjustment of a timeline if needed. But again, also may mean that this is a way in which we are reducing duplication of efforts as well. Okay. Oh, Jeff.
Just a quick question, because it will affect, the answer will affect, I think, our planning and talking today, but unless I'm looking at an old bill, I'm looking at 6900 and it mentions strategic plan by December 1, 2024.
Oh.
Unless that was changed and I'm looking at an old version. So if that's the case, we may have more time than we thought, which would be nice.
We will double check that, Jeff, because that would be very nice.
So there is one in 2023 December and there's another one in 2024 December.
Yeah.
So there's 2. Mhm.
Awesome. Thanks. And
We have one more question, Erica.
oh, so sorry, Alice.
I thought I saw somewhere in the materials that there were suggestions for additional work groups, not to make more. Is that coming up on the agenda?
That's coming up.
Thank you.
Okay, at this moment, I'd like to give Karen the floor to speak about some of the meetings that she and I will be engaging you all in.
Wanted to give you a heads up that I'm hoping that we can meet with all of the key state agencies that are touching families and support for families directly. Also to meet with a variety of providers and get your perspective on not only this plan, but how you see the system working now, information about linkages and working relationships, to kind of get into the weeds a little bit about what do we have now, how does it work as a system? We talk about systems, but systems imply collaboration, linkages, connections, processes that you join together. I'm also hoping that I can engage some families and family groups and sit with them and hear directly about their experience. I've found that in my work to be really helpful. And I'd like to go to maybe 5 or 6 key school systems around the state and say to them, I'm here on behalf of work we're doing at the state level involving children and children's mental health. What are you doing at your school? Some schools have fairly developed a mental health response teams within their schools. Other schools don't seem to. So I'd like to get kind of an overview of that. And then last, really speak to any advocacy groups that would be available to speak with me and hear their perspective on their priorities for the advocacy that I could do, or we could do, or you could do. just to give us some, just another person and opportunity to learn from our broader community. So I'll be setting that up and actively reaching out to some of you, to DCF, to DSS, start with the big state agencies, to DEMIS. And I have a set of questions that I'll be asking of each place, and then really looking forward to not only your feedback on those questions, but your general perspective on what your priorities would be if you were sitting in Erica's position or my position or your position. So I look forward to doing it and working with all of you. Thanks.
And so with that, I would also like to recommend that, and we have already started receiving some of these emails, but if you have a specific recommendation of somebody that we should be connecting with or an entity that we should be connecting with, please send it to us, because we are compiling that list and starting to make those phone calls and setting up those meetings. Okay. And in regards, Alice, this is to answer your question earlier. So in regards to feedback, this is very much a draft. This is how we would like to propose we structure your work. One is organizing in a set of work groups and subgroups, which we will need. We don't want to inundate with too many subgroups and work groups, but enough that we can be responsive and productive and non-duplicative. Two, that those work groups would have co-chairs that would help to lead that work and would work very closely with us to set the agenda, to identify what specific data is needed, to identify what specifically the questions are that need to be responded to, and or to identify the strategies and make those recommendations for improving the system. And then the other piece is prioritizing the work. I'm looking over at Sarah because I speak to her quite often when we talk about buckets. What are the buckets of priorities that we need, and then getting ready to get going in that. And not everything. I mean, we absolutely know we need to 100% respond to the children, but we need to do it well, right? And we need to do it in with a set of sort of how are we going to prioritize this, and not say that we're leaving anything behind, but know that maybe we need a little bit more time to get certain things done and be okay with that. Okay. And so with that, there's another QR code. You can scan that at your after you leave this meeting. Not today, there is a set of questions for you to answer. We do wish to have you give us feedback on the proposal. Alice, this is an opportunity for the members and yourself to let us know, listen, you didn't get it right. It's okay. We want to hear that. Or you got it right, but you're missing a couple of work groups, or you're missing a certain area of focus, and make those suggestions. Also, the QR code is an opportunity for you to volunteer as a work group member and or to be considered as a co-chair of the work groups, which we will need. We will need those individuals. Okay. All right, I'm going to pause and allow for questions.
And we'll also need individuals who may not be a part of TCB, but are interested in the work to volunteer as well. So if you know of other individuals, it will take a lot of volunteers to do this work in the way that we're hoping to get it done. I am hoping that we have that type of participation, but that's also important as well.
That's a very good point. I also want to say that the work groups the majority of the work groups should be comprised also of non-TCB members, right? Because there are so many stakeholders out there that are doing this day to day, practitioners, administrators that have a lot of the experience in the answers. And so they can help make this a much more robust discussion and be able to be part of the work, which I know there are many people who have reached out and said, how do I get involved? So this is how you can get involved, is through the work groups.
Thank you so much. And were there any other? Oh, I'm sorry. Senator Moore.
Just to add on to what you're saying, Erica, I would ask everyone who's on the committee to also think about who is out there in the community that you think is someone who brings information, experience, background. Perhaps it's family connections that know how to speak for families, or even families, because we need their voices as well. Parents who are experiencing some of the things we're working on. So I would ask all of you to be ambassadors and emissaries for this work. That's how we will bring a really robust group together. Thank you.
Just a follow-up question. Do you want the chairs of the committees or the work groups to be committee members, or can they also be people from the community?
They can be people from the community. So, oh,
Thank you, and I thank everybody for being here. There's one sort of committee that I'm sure a lot of people are looking for, but I think as we talk this through, we'll see that it's embedded in every one of them, and that's finance. Finance is in every single component that we're talking about in the subgroup. It's not one that's just isolated in it, because it's all embedded in the work that we're going to do in TCB. So I think as we start to work on this, we'll find out that we will be talking about policy, and then we will include how finance will be a part of that discussion. So I just
Sure.
wanted to talk about that.
correct. And I would also suggest that that also be very much, very defined in your strategic plan. It's embedded through every aspect of your work. And as well as, and so not only the finance, but the data piece, right? That we do need, I think, I'll just speak to the other committee that we work very closely with. We do have we purposely call it a cross-agency data sharing work group for a reason. It comprises of all those data people that we need from all the different state agencies that hold the data, or other entities that hold the data. And it's a great way to not only identify, does it exist? If it does exist, how is it being reported on? You know, what are the outcomes that we're seeing? If it doesn't exist, what does it take to develop it and report on it? So that cross-agency data sharing work group should be another fundamental practice across all the work groups as well, finance and then including the youth and the family as well, and into this work. Jeff, you had a question? Oh, no, oh, sorry.
Erica, yeah.
Oh, Sarah, and then Dr. Gordon.
Yeah, so first, thank you for setting the table in a very detailed and challenging system transformation effort. I think it's going to be really worthwhile. And just one observation, you know, I think that the work is massive, right? And so my instinct is the fewer work groups, the better, right? And I would have said, you know, finance, infrastructure, which to me is really examining sort of the data infrastructure and sort of infrastructure for system design, and service array. And that under service array, not to get too in the weeds, but you can then get at, under each of those, you can get at all the other things, right? Workforce, prevention, underserved populations, and then within that start to peel off, you know, lower hanging fruit and things that take longer time. But those would be the three main, from my perspective, sort of the three main buckets. I know folks may have other opinions about that, but it gets to be really sprawling, as we all know, right? And people are, you know, a lot of people are on lots of different committees. So that's just one suggestion, but appreciate your work on this.
I too would like to echo my thank you for the work that you guys have done so far. I want to actually second Sarah's recommendation, because I think that is a really good way of helping us think about what are the goals that we're trying to actually achieve. And so if we were to think about those three committees being kind of the lead, and then I always ask any subcommittee that comes from it to think about how does the work that we're doing feed into that larger goal that we're actually trying to accomplish within this larger committee. So I think that that'd be really critical. Second issue I would want to raise is one around, and I hate to use this word, but power. And so if we're going to ask folks to lead a group, a work group, and not have voting power on the committee, it puts them in a really weird conundrum, I think. And so I would want to kind of challenge us to think about, you know, who is at the table, how we leverage the resources that they bring to the table, and how do we then think about their voice, and I do really mean that in a literal way, their voice in the decision making that happens in the work that's there. So I just want to add that to the conversation for us to think about as we think about who leads these committees and where they sit within this conversation.
Rep Exum?
One point about the work groups, I'm thinking about some of the people who could really be at the table and add some rich perspective. They don't necessarily have time to participate during the day. Are we thinking through potential opportunities to maybe make this off normal business hours so parents who are impacted or clinicians who have to work can also participate?
Yeah, and so one of the things that both you and Dr. Gordon are bringing to light, I didn't mention on here, is that we typically also like to produce an orientation manual or a how-to manual, for these committees as well, and which sets sort of the how we're structuring ourselves and then our agreements, right, of how we're going to do this work. And so, Dr. Gordon, when you bring up the question about, or the term about power, right, and your co-chairs, where we have seen that in work group co-chairs, they may not necessarily be voting members. Those are the conversations and decisions that this committee is going to we need to engage you in and make decisions on. Is that, where do you all want to land with that? Because that will come up for you. The other piece in regards to the after hours, that's the other, area of space that we need to make decisions on. When do we want to meet? What is the frequency of those meetings and at what time? All of that. And so I think it's dependent on what that, if this committee makes a decision that youth and parents and the community need to be part of everything that's embedded in this, we may need to adjust the meeting times for some of these work groups. And so being open to that. The other piece with your legislation, it does talk about including youth and parents and families at the table. Something that we have a barrier that we have reduced in the JJPOC is that some of our youth and parents have transportation barriers. They have daycare barriers. And so part of what we've done there is that we have, provided stipends to eliminate those transportation barriers. To get youth here to meet with you all for childcare. Those are significant barriers. And so the stipends do go a long way. And so that's another decision that we can make together. And we, as the administrators can do provide stipends to them.
I would just like to add, I think that's a really important component. And when looking at when we started the legislation, we had a meeting in November from the legislative side, November of 2021. It was parent voice that caused Speaker Ritter to say, this is what I'm hearing. And this is what's taking place. And how can we respond to this better? And it started us creating that huge piece of legislation that really brought us to where we are today. So embedding, the voices of children and parents, I think is incredibly important for us to figure out. So I think that's a really great recommendation. Thank you for that.
I'm being mindful of the time. I do see one hand raised, Representative Nuccio.
Thank you. I just wanted to weigh in on the structure. I like the structure as you have it. I don't agree with the last couple of speakers who said we should minimize it. This is a really broad scope issue, and they're very definitive issues within those silos that you had. For instance, school is much different than service provider. I would not want to see these collapsed. I think we have enough people on this commission that we can really focus in on these specific areas, and perhaps maybe add a finance piece, or maybe add a finance subgroup to all of these pieces that has like a standard set of people that are on it. For instance, Tony and myself are both on this committee. We're both she's chair and I'm ranking of appropriations. So having finance people standardly with these subgroups, I think would be good, so they can kind of pull the full picture together. But I would not really want to see this collapse into three. I think we're going to lose a lot of the individual pieces that go into that. I'm very excited about the service piece and looking at providers and provider groups and insurance companies and how we can kind of better that relationship. I had legislation on that passed my very first year here. And unfortunately it never got done because nobody ever assigned anyone to the work group, which is not shocking for what happens up here in Hartford, but that's what happened. So looking at these as the individual components, I think helps us build a better picture of what we need, what we have, or what we're lacking here in the state of Connecticut for behavioral health resources.
Can I just quickly address? So Rep. Nuccio, we already had that in mind as far as the finance piece with you and Rep. Walker. We have Senator Austin here, and we did want to embed that within. So that would be one of our recommendations. So thank you so much for adding that. Totally agreed. I'm going to turn over.
And if I may, Madam, through the chairs, one thing that to underscore the importance of family and community voice, I ask us that we consider deploying ourselves into community. I really appreciate the stipends of bringing people here, but being in community provides returns that are really only tangible when you're there. So I suggest that we really try to do, especially in our middle and long-term work. And then secondarily, in terms of the orientation that I always bring, at least for myself in this type of work, is that this is in so many ways our role in this is systems work. The work of behavioral and mental health is lifelong work for the individuals and the families that are experiencing this. Our role is to provide the systems that are most inclusive, welcoming, and responsive, so that then families can live their best lives. So I just hope that we remember that our work is to make our systems as accessible as possible.
It's funny because the work group I wanted to add was finance, but the only thing I would add is that it's important to recognize that the systems that are built in Connecticut are financed both by the state, by the federal government, and by private philanthropy. So that just making sure that when we're looking at all the dollars that are invested, that we have a more coherent sort of understanding of, how things are afforded, to be honest with you, because it's not fully state at all. So.
Could I speak to Alice's excellent point, please? I mean, I think it's really important to know exactly how much we're spending in children's mental health and where that money is being spent, and not just in a sort of global way, but almost, down to the dollars, what program is getting what money. And I think too, when we're looking at the money, we have to also look at, and I know we're doing this, but so we can discuss it as a committee, what services do children need, who decides what these services are and how much, how do we know this, what are the different step downs in each area? I don't know where that fits in any of this, but I think it follows your point.
Yeah, I would say that if you take a look at the table that has the work plan timeline, what we did there is so some of what you, Jeannie, what you're mentioning, and Alice, what you're mentioning too, in the sense of the sort of the finance pieces, how much are we spending? How do we know it's being spent appropriately in the right buckets, right, of services and gaps and so forth. Though you all have outlined a lot of that needs to be done. So I think that as you're giving us feedback on the next steps, the task, and we're operationalizing this is where you'll need to also give us feedback as to which one do you want to prioritize to, how do we prioritize and how do we collapse together maybe some of these pieces. So for example, what are the services that we have in place and what are the gaps that we have? We know that that's something that we need to do there, but then that can be also tied with, well, what's the spending on it, right?
The one caution with trying to quantify the dollars spent and peg it to children's behavioral health is that I don't know if it necessarily fits in a bucket, and it may run counter purpose to our whole movement towards integrated primary and behavioral care. So when we try to do these exercises to quantify how much money do we invest in children's behavioral health, it's a little bit of an amorphous number because of that. And I think that's partly a good thing. So we could recognize some limitations to that.
All right, so I'm taking a look at the time, and I last I would like to say is that, as I said, please complete the survey, email us, call us, set up some time to talk to us. We want to hear from you. Karen and I and the team will also be going out in the next couple of weeks to meet with different system partners. And so if you have suggestions on who else we should be meeting with, or entities that we should be meeting with, please send that over. I'm going to pause because I see a hand raised. So.
Yeah, sorry to go on a tangent, but I'm wondering if it's also possible to get more of a status update on action items from the bill itself and where those action items are. The bill was a great bill, and I think that it would really inform us and help us to not reinvent the wheel. If there's been hard work, particularly by our agencies, to do some implementation of the bill, that we all get a briefing on before we jump into strategizing and action planning.
Very good suggestion. Thank you. We can definitely work on that. So the meetings will be taking place. And then the other area that many of you have actually asked for is some level setting training. That we added a slide or a tab on acronyms, and we know that there's 101 acronyms. We also know that this system is a very big system. We know that there's multiple stakeholders involved, and there's other committees. And so I think it's important that we also have take some time to do some level setting, not only to address some of what you just asked in regards to where our things are and some of the action steps that have taken place in the legislation or in the bill, but also what does the system look like, sound like, who is really accessing those services. And so some level setting training, or some, I don't want to call it training, but some level setting kind of informational that would, I think would benefit all of us to receive. So Karen and I will be working with some individuals and who are part of this meeting to begin to do that work as well and bring that forward to you all.
Thank you so much. And I know we could talk about this for quite some time. But we do also want to hear, speaking of, ways to look at something that we want to ask about sustainability, but that we're excited is an example of legislation, is looking at our crisis centers and getting an update around where the crisis centers are, and to hear what that looks like and ask questions around that. So we would like to kind of transition at this time. But I definitely, that's one of the reasons for this committee, to be honest, is to really look, this such a big piece of legislation. And I know a lot of wonderful work has started, but what is it and where are we? And so that certainly will be a part that's addressed. So at this time, we're going to transition to DCF. Our good commissioner is here. And I guess I'll just turn it over to you to get us started. And then kind of a brief piece from DCF, if I may ask, so that we can move into our reports from our UCCs.
Very brief for me, because I'm excited to be able to have the team here assembled, really get into the nuts and bolts of the urgent crisis centers. I just, one point that carrying on the conversation that we were just having to consider as we think about the existing bodies is that the state agencies want to be as responsive as possible. And earlier this spring, some of us did just a quick exercise of the statutorily mandated boards and commissions that we are responsible for. And for instance, DCF is 40 plus, and that's not counting subcommittees. So as we think about creating more work groups, I really would urge not for this committee to make recommendations of things that are similar to either be sunsetted or rolled in, as opposed to just the connect the dots, because it does get unwieldy and it's hard to then produce the deliverables that are expected of us. And this is not a DCF urgent care. This is a collaboration from an existing work group that really started to look at what were the gaps along the children's behavioral health urgent care and crisis stabilization. There was actually a work group that was put together that started to build the skeleton around this. And thankfully, with the ARPA implementation dollars, we were able to actually see them come to fruition. And if you haven't had an opportunity to actually visit some of these urgent crisis centers, you will be completely blown away, as I have been, and impressed with not only the subject matter expertise that we have in the clinicians who are working in the centers, but just the care and attention that has been dedicated to the children and families of Connecticut. So on behalf of Department of Social Services, Department of Public Health, State Department of Education, and of course, DCF as the executive branch agencies that were kind of in partnership with some of that, along with the work group and all of the folks that had rolled up their sleeves to really bring this to fruition. We are happy to talk today about Connecticut's urgent crisis centers. We have the division director from DCF, our senior administrator, Dr. Frank Gregory, who will be leading and facilitating the conversation. And we also have the providers, the 4 that are existing right now, and that have taken such great care that I just talked about, from Waterbury Wellmore Behavioral Health, from Hartford, the Village for Families and Children, from New London, the Child and Family Agency of Southeast, and in New Haven, Yale Child Center and Yale New Haven Hospital, represented by that urgent crisis center. So with that, Dr. Gregory, I'll turn it over to you.
Thank you, Commissioner. And I will give some brief context and background, but then really rely on my provider colleagues to really invite us into the program, what it looks like, how it's working, and most importantly, what youth and families can expect from that level of care. So we're very excited for this opportunity. And urgent crisis centers are a new level of care to Connecticut, and they will be accepting referrals 24 hours a day. No appointment needed, walk-in basis, will provide a full crisis assessment in a safe and effective and supportive environment for youth and families experiencing behavioral health crisis. It's not a bedded program, quote unquote. It's intended to be same day, and youth and young adults will go to this center as an alternative to an emergency department. And it's important to note, this is not a program for youth who need to be in an emergency department who are going somewhere else. It really is for youth who otherwise might have ended up in an emergency department who really didn't need to be there, but for lack of a more appropriate resource. And so that's what this is for. The UCC will provide triage, de-escalation, crisis stabilization, assessment, but really as important, work collaboratively with the family to understand from their perspective what their needs are, to partner with them in safety assessment, and to really partner with them on connections to ongoing care. As the commissioner said, our partners in this have really been working diligently, and I can't exaggerate that. They really have been working intensively, each on their own program and also across providers to develop this level of care. So why urgent crisis centers? It's an idea that's been talked about for a while, actually. The Children's Behavioral Health Plan back in 2014 identified in its discussion of providing an access to an array of behavioral health services, the need for alternatives to address the high rate of ED utilization, and specifically identified short-term behavioral health assessment and crisis stabilization centers. Moving forward from that, the Behavioral Health Plan legislation authorized an implementation advisory group, which convened several work groups to look at different aspects of the system and really continue to drill down on this, and reiterated that emergency departments were routinely overwhelmed by numbers of patients presenting for care, which overtaxed the resources in the EDs, as well as impacted the patients themselves and how long it took for them to get the care they needed. A significant percentage of these youth were believed not to have needed to be in the ED necessarily, in part as evidenced by the fact that many of them were able to go home after a period in the ED. And also, it was believed that EDs varied across the state in the expertise and resources that they had related to behavioral health and children's behavioral health in particular, and their community connections to local systems of care. So sometimes this might result in youth actually having a higher likelihood of being hospitalized, depending upon where they were. Next. The work groups also did a lot to elicit family input, and one mechanism of that was to survey families through family advocacy organizations and local community collaboratives. And the feedback that they received from families spoke to many aspects of the system, but in this particular regard, I think it boiled down to two main points. One was, when we're in a behavioral health crisis, we don't want to have to go to the emergency room. And if we do go to the emergency room, we want to experience something different than what we do now. And so in terms of the first, creating alternatives to emergency departments, certainly expanding mobile crisis services, and again, their identification of this need for someplace else, which very much fits a description of what has become an urgent crisis center. And within emergency departments, speaking to some of their concerns, looking to enhance the experience of the staff who are there, create more appropriate and less overstimulating spaces, lessen the time that people have to spend in emergency departments, and improve connection and communication between the hospitals and the community systems of care. This program is not only responsive to local needs, it really is reflective of what's been identified nationally as best practice. So SAMHSA has published guidelines related to best practice for behavioral health crisis care. And they identified that a system should have three core components: a regional crisis call center, mobile crisis response teams, and a setting which can serve as a crisis receiving and stabilization resource. As they've talked about it, someone to talk to, someone to respond, and a place to go if I need to. And so this, in addition to responding to local needs, really completes that third piece for us of a comprehensive crisis response system in Connecticut. We were asked to speak a little bit to where are these and what did they cost. So we essentially have created one in broadly north, south, east, and west. Greater Hartford, Greater New Haven, Greater New London, and Greater Waterbury is where the programs are cited. The Hartford and New Haven programs are intended to be larger, and the New London and Waterbury are smaller. So they're 12 youth and daily capacity, and the smaller programs up to 24 in the larger. And you can see the associated costs for 12 months of funding. And we should notice, as been referenced, the funding to date has been made possible by ARPA resources. And so these are the resources that have been put into place. Next. And it's been implementation that, as I said, has involved not only several of the providers themselves, but other agencies. So the Department of Social Services has been involved in collaborating with us and in meeting with the providers to talk about program-specific billing codes and fees, really drilling down to what that would need to look like, recognizing that they would need, in consultation with OPM, approval to move forward with a proposed state plan amendment to the Medicaid state plan, et cetera. So they're working diligently on that, both on what the codes would be and the associated fees. So it's looking like they will create a specialized service type of UCC, which would have an associated service code for approved providers in the network. The Department of Public Health has been working with us to, related to separate legislation, to authorize ambulance transport to UCCs in consultation with supervising hospitals. And so through their Department of Emergency Medical Services, they are going through the process of establishing those protocols, and they anticipate the legislation identified the end of this calendar year as the timeline to have those in place. And the Department of Education as well has been very helpful in helping us get the word out. Commissioner Russell Tucker gave a special shout out to this program actually in her welcoming address to the state school superintendents a couple of weeks ago, and invited us to present information. She's also invited us to participate in the statewide special education conference at the end of this week at the convention center. We're working with other entities to help get the word out. So United Way is partnering with us to get word out to pediatric primary care offices, other community stakeholders, so that we can augment the work done by the local providers to get the word out. One final slide, and I'll turn it to the providers. I've referenced that our providers include both community nonprofits as well as a hospital, and we were asked to speak a little bit to that. You can see here that sort of comparison that the program components of 24/7 availability, crisis triage, nursing assessment, psychiatric assessment, strengths and needs assessment, working with families on safety planning, connecting to care. The expectations of both programs are the same. I think it's fair to say that the sort of growth space for the nonprofit providers has been in some of the 24/7 and emergency access that obviously hospitals have had as part of their core business for a long time. For the hospital, I think it's fair to say that the developing competency will be some of what the nonprofits conversely have been very involved with, which is the community collaboration and connections to follow-up support. So ultimately, the expectations of what a family can expect from the program are the same, but the providers are each in their own way coming to implementation from different perspectives, and the program continues to evolve. I'll be available for questions, but want to turn to our provider partners, each of whom will introduce themselves as they start, beginning with our provider partners at Wellmore.
If I could,
Yeah.
just before, and thank you so much for that presentation. I just want to give Senator Austin a chance to have one quick question.
Sure.
Thank you. I appreciate that. So I have two questions. One, relative to the costs, when you said 4.2 million all the way down, is that the O&M costs, or is that a combination of O&M and the capital to set it up?
It would be an annualized operating budget. The actual startup costs included some renovation and startup costs, which in some instances were offset by the operating funds they didn't need because of the program startup. So that's why I put it in this way, that a 12-month funding for operations would be this amount, and this is what was published in the RFP. But the specific, what each provider needed specifically for startup and renovation of their space was somewhat different. And we could supply that through our fiscal office if you're interested in that.
That would be great if we could get those
Yeah.
numbers, so we can look to see what we actually have to start thinking about how much would come in under Medicaid or Medicare or any of the other funding streams. What do we have? What would be covered by insurance? It's something that we would like to I would like to at least see an analysis of what that is. And my second question is relative to the citing of the places that you that are there, all good places. The Eastern Connecticut one, the New London, Willimantic, Norwich, does that also include Northeast Connecticut? So while not a lot of people, not dense in population, one of the problems that we have is relative to the distance one must travel for assistance. And so is that the intention right now, is to figure out, that would be the bricks and mortar, so to speak, and perhaps the other ones would be serviced by mobile crisis centers? Is that the thought process right now?
Well, in part,
And I use Eastern Connecticut, but the same thing would be true in Northwestern Connecticut
right.
too.
In part, the siting was guided by the providers who responded and proposed, the implementation of the program and where they proposed to site it. So admittedly, a program in New London that's intended to serve the eastern part of the state is somewhat distant from some parts of that catchment area. So I think for that northeast part of the state, it really would be the intersection of the catchment of the New London program and the Hartford program, depending upon which was more accessible with for a family. Best case, as these really flourish and are shown to be viable, we would be in a position potentially to look at, okay, where can we add to this? But right now, this is where we've started.
Because that's something that I think the need is there. But I don't want to forget the more rural sections of our state, which have an equal need, but have less access right now. So thank you. Thank you very much.
Absolutely, Senator Austin. And we're ready to now hear what you're seeing and experiencing. Thank you so much.
Good afternoon. My name is Kristen Presido. I am the Vice President of Child Services at Wellmore Behavioral Health in Waterbury, Connecticut. So as we move forward with today's discussion, it's really important to reinforce the unique partnership that's developed between those of us who have implemented the urgent crisis centers. From early in the development process, the people at the desk who you'll meet today and our key UCC leaders have been talking together weekly, sometimes more than that, brainstorming together, planning together in order to ensure that families that present to the urgent crisis centers are receiving a consistent clinical experience, no matter which center is utilized. We have created and upheld the same vision for what is possible, a calm, supportive environment that would help families be able to open up and engage with a solution-focused approach to safety, support, and connection to care for those children and youth. The emergency departments certainly have a place within the system of care for those with acute suicidality, aggression, self-injury, psychosis, those who cannot be safely and medically managed in a less intensive environment. For everyone else, however, the urgent crisis centers present a new level of care for crisis management and immediate access for evaluation, support, and connections to care. We have kept the family's perspective in mind in all of our discussions and our planning. We sought to create an environment that would remove the barriers to accessing crisis mental health care in our state. At every discussion, every week, these words described our approach: collaborative, inclusive, deliberate, innovative, partnering, and committed. With each decision made by this group, we sought to create an environment that was supportive and welcoming in the face of a crisis, that would foster problem solving and safety planning in a different way. Let me just walk you through a family's experience of the Urgent Crisis Center and allow you to look at the UCC environment and reflect on how different it appears from a hospital setting, and hear the way the family receives supports from us. Families may learn about the UCC from a variety of sources, including pediatricians, mental health providers, schools, police, supportive programs, 211, mobile crisis, and other community entities. Although community providers and partners can call to give our staff supportive information, the UCCs exist as a walk-in level of care, meaning that families choose when they want to go, or they can access the UC in the midst of a crisis. As families walk into the Urgent Crisis Center, they are welcomed and asked what's happening that brings them to the UCC. This may include a change in the child's behavior, increased presence of disruptive or challenging behaviors, anxious or depressive symptoms, withdrawal from regular activities, including school, peers, and social groups, or a variety of other presentations. Of note, however, is the fact that the family defines the crisis, and therefore that drives the boat in terms of our engagement with the family and our problem solving. If the triage nurse in our first discussions with the family recognizes that the youth presentation warrants a medical evaluation or medical support, this nurse will facilitate a discussion of that with the family, presentation of the clinical information to the ED team at the hospital, and ensure a smooth and safe, timely transition to the emergency department for evaluation. It's important to recognize, however, that the physical space of the urgent crisis centers has been quite deliberately structured to support children and youth. As you can see in these pictures, we have comfortable and safe furniture for the youth and the families to sit on. Our space is colorful, yet calm and child-friendly. The walls are decorated with relaxing scenes, artwork, or therapeutic posters. Each UCC room has toys available. Some rooms are outfitted for a particular age range, or with sensory tools like bean bags or rockers, or weighted stuffed animals like the orange dinosaur in the lower right-hand corner. The rooms are set to be more like a living room than a hospital room. Although some are equipped with special furniture, walls, and other equipment that help to calm and contain escalated youth, it is still a living room setting. Throughout the family's time at the UCC, there are a variety of clinical and supportive conversations and assessments that occur. Some are just with the youth, some just with the parent, some even with siblings or other family members who may have presented with the youth. But we always bring the family back together and do brainstorming and discussions with the child and the youth together. The goal is to ensure that the youth and the parent and the guardian feel heard and understood, that their perspective has been respected and honored. And the approach to these clinical discussions are informed by research-supported approaches of solution-focused therapy, crisis intervention, and trauma-informed practices. This process of slowing the conversation down to explore the crisis with each person has rich therapeutic value as it moves from each person from the point of crisis to a more solution-focused approach. The parent also engages in a discussion about how the youth's crisis is impacting the family as a whole, and whether additional services or connections might be helpful, ranging from additional clinical supports to pro-social activities or concrete services. As the assessments are completed, the team comes together to talk with the senior clinical staff, often APRNs or psychiatrists, to review the clinical assessments, what we've learned from the families, and any unmet needs. The clinical review helps the team connect the dots of all the participants' stories while starting to create the structure of a safety plan and a list of potential connections to community resources that may help the youth and the family. If one component of the clinical review indicates a need for psychiatric evaluation or medication consultation, this can occur within the UCC structure. After the clinical review, the UCC staff work together with the family to flesh out a safety plan and connection to resources that make sense for them. The safety plan has components to help the youth and the family members identify emotional safety, physical safety, supportive people, and ways to address escalating emotions earlier in the crisis process so they have a better set of coping skills. The plan is co-constructed with the family, meaning that everything is based on the information that the family has provided, suggestions that make sense to them and that they will truly work with them. The plan's not finished until both the parent and the youth agree that it'll work for them.
Hi, I'm Erin Saylor from Child and Family Agency, and I'm the Chief Operating Officer there. So as Kristen and Frank said, I think the key with the UCC, especially with discharge planning, is intentionality and collaboration and coordination of care. So once the safety plan is developed with the interdisciplinary team and recommendations in the discharge plan is made, the family will work with the discharge planner and will coordinate care with current providers that may be in the picture or brand new providers that are either coming into, because we're working with families that maybe have never been in services before or are already embedded within the system. So we're very intentional about those partnerships. We've worked really hard in this buildup to develop relationships and partnerships with emergency rooms, psychiatric hospitals, mobile crisis is a really key partner for us, schools, police departments, outpatient providers, et cetera, so that we really can seamlessly get families to the right program or service that they need. I think you'll also hear we're not talking about the client, we're talking about the family, because we really believe that a child in crisis is a family in crisis, and we really need to wrap around everyone in order to ensure that healing can happen. So the discharge planner will work with the family. They'll connect to care. As Kristen said, we're trying to do provider meetings on site if that's possible, if we can get everyone. We all have technology in our systems so that we can either bring people in or do Zoom meetings with providers at that time to make sure everybody's on the same page and coordinating that care. The not all kids are going to be appropriate for outpatient level of care. Sometimes it might need hospitalization. So again, with that partnership with EDs, we'll be calling the emergency department, working with their psych providers to figure out how to get them there safely. In addition, there might be kids that are at the emergency department that are ultimately more appropriate for the urgent crisis center. So we're hoping to really have some good collaboration there. We also recognize that, again, it might not just be the mental health crisis that's contributing to the mental health crisis. So we're working with the families to connect them with additional resources. It might be connecting them with a medical home if they don't have one, school-based health centers, food banks, and other basic needs to get them really connected within the community. And the other thing that I think is very unique about the Urgent Crisis Center in terms of discharge planning is that we're working with the family to connect them and staying with them until they're connected to that next level of care or that next service. We want to make sure that that warm handoff happens. So we're going to stay involved and check in by phone every day. Some of us have an app that we're using because technology seems to work with some families called PUPs. Also, some families, a phone call check-in isn't going to be enough. So our partnership with Mobile Crisis is absolutely key. So we might be connecting with them and having them do the bridge because they can do ongoing treatment and connect in the home with the families. So Amy is going to provide some more context for you.
Hi, everybody. I'm Amy Samela, the Vice President of Residential Programs at the Village for Families and Children. I get the pleasure of really bringing in the family's voice to this experience at the UCC. As Frank, Kristen, and Aaron have shared, every aspect of the program development has been intentional, from the physical plant to the aftercare services. One of our intentional focuses, of course, though, is the family and youth's experience. In order to plan for this discussion, I have had the pleasure of really talking with all of the UCC providers about the cases and the families that have walked through the door. So how are we doing? The community UCCs have seen over 60 kids since we opened, which hasn't been that long. And while many of these families have things in common, there have been many differences as well. Some families have never sought mental health treatment at all, ever. A few just moved to Connecticut and didn't know how to access services. Some didn't have insurances and didn't even know where to start. And of course, others have been well experienced and have serviced all of the continuum of care within the state of Connecticut, including trips to the EDs. The words chosen on this slide are intentional as well. In each assessment, the teams take their time and they listen. After about 4 to 5 hours in the UCCs, the families have voiced feeling connected, safe, and heard. Let me briefly share a family's experience in coming to the UCC. We had a mom come. She came to the UCC with her 14-year-old son because of family conflict in the home. After about 30 minutes, the mom starts taking things out of her bag: cereal, milk, ramen noodles. We take a moment and we ask her, "Are you hungry? Do you need something?" And she said, "I'm preparing myself for my long evening that's going to go into the wee hours of the night." And that was an example of her experience each time she went to the EDs with her son. So after the few hours of doing all of our assessments and connecting and doing a really good discharge plan and an intensive safety plan, she was ready to take her son home. She waited in the waiting room for a few seconds, and then she asked to see the clinician again. The clinician walked out the door into the waiting room, and now we're at 11:30, and she gave the clinician a hug. And that was all. And they sat embraced in that hug for a few seconds, and then she walked out the door. That's an experience at the UCC. The experience doesn't end when the family walks out the door. The aftercare services of the UCC, as my colleagues were talking about, is really what the families appreciate and what we feel is literally the integral part of what makes the UCC a new level of care. While the families leave and they talk about feeling connected and heard and safe, it's the calls that we make after that really show the work that the UCCs do. We review the safety plan, we review with them the next level of treatment, we ask them how they're doing, and then we talk to them until that next level of care has started, whether it be outpatient, ICAPS, right, mobile crisis. They know that the next day we're going to call. In addition to that, if they were there at 7 o'clock at night, we're not calling them until the next day during that shift so that they're hearing from the same person that they saw when we were there the day before. So how are we doing? Well, those are some of the stories, but we are also working on family surveys so that we can hear from them regularly and collect that data. One theme, though, that is shared, whether it's our UCC or my partner's UCC, is a quote that seems consistent. What they tell us is that you're doing everything right. You're doing exactly what you need to be doing for us. I want to share one more story. This was something that I experienced as I was giving a tour of our UCC. And it was with a visitor, somebody who wanted to see what this was like. And as we were walking through the UCC and he was asking me questions and I was talking about the families and all the good work that we're doing, he paused. And it took me a second. It kind of felt like minutes, but I know it was only a couple of seconds. And when we caught eyes, he had tears in his eyes. And we just sat there for a second. And then he decided to tell me his story of where he and his wife, it was about a decade ago, where his son was in the ED. And he remembered, he was reliving it, where he watched his son on the gurney in fetal position. And he said, thank you. Now I know that families won't have to experience what my wife, my son, and I have to experience. So thank you.
I just want to thank you so much for that. And I know Dr. Taylor will be next, but I think you painted an image that if I certainly had to describe what I had in mind when these were being developed, you described it because I do know what it looks like in the ED. I do know what it looks like for these families, what it feels like, and having the calls after that do or do not come. You hear that, we've heard that, and then they're left there alone and having the environment that sounds very much like the one you described being so appropriate. So thank you for sharing that and really bringing that to this space. It is so hard to get all of this in the amount of time that we put aside today because we are just getting organized and structured. I want to be respectful, but I also would like all the presentations that you've prepared and this information to have an opportunity to be heard. So I'd like to do two things if you would allow me this time. If you had planned to leave today at 3:30 and you have to, we understand that. If you're able to stay until 4 o'clock or until we can at least hear the remaining presentations and have a Q&A, I would really appreciate that. And we will work as we continue to work and get our group organized. We will work on this time component. We had a massive agenda today as far as what we're trying to get in a little amount of time. And so we are running over, but I think this is really important to hear about the UCCs and at least have a couple of questions and then we can follow up later. So if you need to leave, we understand. But if those of you are able to stay, I thank you for that as well. So Dr. Taylor.
Thank you so much. My name is Dr. Lane Taylor. I'm a child psychiatrist, the medical director of the Village for Families and Children, and it has been an absolute blessing to be a part of the development of this level of care in Connecticut. And the cool thing is it's continuing to evolve. And honestly, after, my colleagues' presentations, I don't need to belabor the point of the impact, right? You guys all know and hear the impact. And it's only been, a couple months, literally. And so, I think that, just kind of pulling out the buckets where we've had an impact on utilization, youth and family experience of care, the outcomes are small right now, right? Our number is small, but it is going to continue to grow. We're in the time where schools are in session, families are in major need, schools are in major need of this kind of support without having to send the kids to the emergency department and potentially having to be overnight. So I don't need to belabor that. I think, though, one of the things that I have on there is making an impact. And I think that we can make an impact in the systems issues, but it takes a collaborative effort. And I know that this is of great interest to all of you on this committee, because that's why you're here, is to think about how do we really make a cohesive, collaborative system that isn't just plopping in something brand new, something shiny and new, and that is sort of takes over or it fails because it's not interconnected. And so I think that the systems impact could be great. I think we have the opportunity to be a hub, but the spokes need to be fixed, right? And that's why we're here. And so, I want to talk about what challenges we have for success, but the systems issues, the outcomes are still in development. And I'm excited for the partnership of the individuals in this committee to really bring that to fruition. So we can go to the next slide. So challenges for success. I think, again, going into the different sections here, and I'm imagining that there are going to be a number of questions that will sort of pull out and flesh out some of this. So I want to also really give space for that. But workforce, right? We've already spoken about workforce here at this committee before our presentations. There's a shortage, not only a shortage of people to do this work, shortage of trained people to do this work, and shortage of individuals who represent the communities that are being served. And so that is a huge piece that we really need to pay attention to. I think honestly, we could say at this point, our teams have done a really phenomenal job bringing in some very impactful, wonderful, excited people. How do we keep them, right? How do we not have them go on to the next thing? How do we make sure that they are still connected to the work in the way that they are? Because it's pretty cool right now. And then going into reimbursement. Reimbursement is an issue across the system, right? Especially for behavioral health care. There had to be a whole federal legislation around the fact that mental health care is underfunded compared to medical care. But I think what we need to think about, not just reimbursement, because if we just look at like the dollars and cents of reimbursement from Medicaid or from commercial insurance, it will not sustain this level of care. We have to think about funding that is going to really continue this level of care, because to be honest, it's high. It's a high level of intervention for crisis for families that is meant to reduce the impact of other levels, costs to other levels of care, other treatments that are out there. So we really need to think about a funding system that is sustainable. And we can actually say there are other states that have put this level of care into place and have been able to, over a span of years, think about how do we make it sustainable. So we can look at New York, for example, our closest neighbor, and really thinking about how did they do that. And it took years for them to figure it out and actually create codes within Medicaid. But we can't just look at Medicaid, and we can't just look at fee-for-service reimbursement. Next is connection to care. It's kind of the point of everybody being here, right? Is how do we make sure that there's good connection to care? I have to say, honestly, we've been quite successful so far in our small group of like just over 60 folks, families that have been served. But the reality is, and I'm really grateful to Senator Austin talking about like our rural communities, right? Because our system is regional at best, right? And our UCCs, they're 4 in the state. So having worked in other levels of care, access to mental health, for example, and having to learn about all the different systems, all the different levels of care that are in different parts of the state, right? Different treatment facilities, et cetera. It's a lot to take in. It's a lot to figure out, because honestly, the way it's set up right now is that you have to just kind of know what's there, right? We don't have a really cohesive way of understanding how these different clinics and IOPs and hospitals and emergency departments, how can we all work together cohesively? It's just not set up that way. So we're fortunate that right now the families that have come, we're able to do that handholding. And the cool thing is that aftercare is really, really a huge component. And our relationships that we've built with as the providers that we've built with the organizations that are in our communities has really fostered that warm handoff, as we call it, of like directly communicating. But let's just be real, that's not scalable. And we want to serve all the kids and families of Connecticut. So we need to figure out a system that supports and allows us to be scalable. And then, I think finally, we're talking about the UCC's embedded within larger systems as a part of the connected care. I already touched upon that, but I think it's just really important to go back to thinking about how do we identify what is success? How do we identify ways of connecting families? There is one aspect that I will point out here, which is ambulance service. That's a double-edged sword, but let's just be honest. A lot of schools use ambulances as a way to get kids who are in crisis to the emergency department. At present, there's efforts toward getting ambulance service to the urgent crisis centers, but it's not yet there. And it is actually a really crucial piece that needs to happen at a state level. It can't happen. The providers can't go one by one to the hospitals that are running the EMS and say, hey, can you drop the kids here? Can we create an algorithm? It just doesn't work that way. So we need to be able to be thoughtful about this as a means of connecting, especially our rural communities to these centers, because transportation is impossible, right? And I have a love-hate relationship with Veo, but which which is a medical transport system for those who don't know. And it's only for those who have Husky, right? And so it still only like reaches a minority of kids. And you know, as I think I'll give them benefit of the doubt, they try. It's just not as reliable as what's needed, especially for kids in crisis. So I want to really wrap that up because I know that there's a number of questions out there, and I'll stay, but we'll all kind of rotate as needed.
I just wanted to add, so I'm Jan Ponson and I'm representing the Young New Haven Children's Hospital. As the UCC site, my colleague couldn't be here today. And for us, where we are a walk-in clinic and we receive ambulances, about 30% of our arrivals are by ambulance. And many of those are from schools. So I think this ambulance question, I mean, all of these are huge issues, but I think that's ostensibly could be lower lying fruit that is quite vital.
Thank you so much. And thank you for giving us all of that information in a quick amount of time. I do have a question. When looking at the picture, and I've been to the Village, and I'd like to go to all of the UCCs, but I'm wondering with the one with Yale New Haven being located within a hospital, what does that one look like? How is that structured?
Well, right now that's the best way to describe it is an evolution towards a UCC model that is cohesive with the other UCCs. So we're all going to have our individual flavor and experience for families, but the goal is to provide a similar experience. It's a warm, friendly setting that families can walk into. Right now, families are largely taken care of in a medical emergency room, and we do have some dedicated spaces. But many a time a family is getting their care with lots of beeps and noises and traumas happening. And so I'm sure many of you have been in the emergency room. It's not a good place to take care of your mental health. So the goal is to move the setting to a different location that's adjacent to the emergency room. So we're building that out. And as we develop more robust training for our staff, clinicians, nursing staff, ED physicians. So this allows us to, so the grant allows us the opportunity to do that training so we can provide a slightly, vastly different experience for families with slight adjustments to how we provide care.
And thank you for that. And what's the expectation on the timeline?
We're going to break, the expectation is to break ground in late 2020, late fall, this fall.
Late fall.
Late fall, yeah.
And I think this is really important because one of the things that is important, I think, from what we're hearing and what we know about the way the emergency room experience feels, but even at one like Connecticut Children's, which is wonderful and really built around children, it's still not ideal when so many of the children don't belong there. So I can imagine that experience feeling really different when I look at the UCC that was established, for instance, at the Village. So I'm glad to hear there is a push to make that change. I think it's critically important to do so.
Thank
So
you.
that's what- thank
I think it's, and
To
just to
help-
add, there are emergency rooms where a child is with adults. And so a 10-year-old first time in the emergency room for a psychiatric evaluation next to adults who potentially have had very chronic illness with a severe exacerbation. That's a really almost semi-traumatogenic experience for someone who's trying to get help. So I think this is very important.
Absolutely.
So to follow up on the fact that you're going to be breaking ground in this fall, what's the timeline for completion?
Well, we hope to get things done in 2024. We don't have an exact timeline, but probably early 2024. We are also, just to reiterate too, we are already a walk-in clinic. We already have excellent partnerships with EMPS, including Clifford Beers. We actually had EMPS embedded in our emergency room for a period of time until we found it was no more effective than just to collaborate with EMPS in their traditional model. So I think we have a lot of the elements that are in place, but it's really going to be more about the space.
One other question when thinking about that is around the funding piece. So looking at how the funding has been utilized when it's essentially within the existing structure. How many children, if I could get that, if you have that available, and what the funding looks like for the children that have been seen at this point?
That I wouldn't have that at my fingertips, and it's hard to separate out who we've traditionally seen, who we would see within this new model. The the answer is that we did try to see if we could establish a partnership locally and do it differently. But that was not feasible in terms of the actual grant amount. So what we're doing is a combination of bringing our own staff and personnel that we're funding while also using some of the grant funding for capitalization reasons. So that's the uniqueness in terms of some of what we've done. And I think DCF could speak more to their thought process on that and their decision making in terms of responding to our RFP application. But that's my understanding of it.
If I could, and I think, thank you, Dr. Ponson. I think he's at a bit of a disadvantage in terms of some of the contractual negotiations. Without going too much into the weeds on it, the Yale contract, essentially, it was Yale's proposal that they provide the majority of their staff in kind, and that they use virtually all the funding to make the modifications to the physical facility. And so while Dr. Ponson mentioned that the physical changes are still in process, the expectation and negotiation with Yale was that they would implement programmatic changes, training the staff, so that the experience of what a child would encounter vis-a-vis the care they receive, that would begin to be implemented up front. So it admittedly is a different model. And so it's not, I don't want to give the impression that it's on hold insofar as the implementation of the care is occurring, but some of the physical plant issues are still being worked out.
Yeah, thank you, Dr. Gregory. So yeah, to clarify, as I said, we're already a walk-in. We're already working with community partners, have been. And in terms of what you're describing, we have already implemented training for our faculty, for our clinicians and staff for enhanced training that all the UCCs are planning to administer to their clinics and staff. Trauma-informed care, motivational interviewing. So I think we're just trying to be cohesive in our approach across the state so that a family could experience, not that families are going to go to different UCCs, but as the UCCs have an evidence-based, informed, and cohesive approach that we can all agree upon, I think was an important element of this project together and why we're presenting together today.
Rep. Exum, you do have a question on chat. The question is, how do the children urgent care crisis centers work with the children mobile crisis?
So I think Wellmore has a unique perspective of being a provider of both UCC and mobile crisis services. So maybe Kristen can speak to that well.
Absolutely. Thank you for the question. So we've received the question a number of times of how do we work together, or how does a family choose? And really it is up to the family to choose. One of the key things that we try to do in our aftercare is provide bridge services, but for families that may be more acute in their presentation, more complicated in the dynamics that are going on in their family, we actually partner with the mobile crisis program while the family is still on site at the UCC. So we're reaching out to establish a follow-up call, home visit with mobile crisis. In some circumstances, certainly at Wellmore, we can call downstairs and say, send up a clinician so we can introduce the family to the clinician from mobile crisis prior to the family leaving the UCC. So again, it's a warm handoff, but it's a warm handoff that has another layer because the introduction happens while they're still in our setting. And then it makes it a much more smooth transition outside of our setting. And then we partner with mobile crisis in providing those follow-up phone calls. They provide follow-up home visits. And again, we both work to sustain the family until the connection to care for the next level of care occurs.
You have another question over here?
I was wondering if I could just quickly respond for those who don't have the mobile crisis embedded, if that's okay, just because we've actually created workflows with mobile crisis that serve the regions that we serve, so that we can make sure that there is an actual like warm handoff in the same way, but just not downstairs.
Okay, I'm so sorry. I'm not paying attention to everyone around me. I'm so focused in front. So Rep. Walker.
Yeah, thank you all for your presentation. It's obviously a delivery of services that is desperately needed in Connecticut. So thank you for that. I'm going to ask a couple of questions about funding, which is I'll pick up from where my co-chair started. when you look at the different models, the one that stands out to me that works well, obviously, is the hospital, because you have multiple ways of billing. How are we going to establish so that you will be, I think I heard them say that they're going to add 3 more codes in Medicaid for you for charging. Is that correct?
DSS is in the process of assessing that. It looks, at least based on the preliminary discussions, that there will be, everyone coming to UCC will receive a similar service for the first few hours. So that would be sort of UCC 1, if you will. And that depending upon the child's specific needs and acuity, what happens from there may differ. So they will have other codes that will accommodate, whether it's the next 4 hours or some acuity basis. So they're working out the specifics of that. But it looks like it'll be a bundled rate. Right now, the providers are eligible to bill on an outpatient basis for individual services, so a psychiatric consultation or a clinician assessment. But the aim is to have a bundled service-specific set of codes with associated fees.
Okay, so we basically would be addressing our Medicaid plan in making those changes. I guess from thinking about this, because they are so important, and as you can hear, some of my colleagues wanted to consider expanding because we know the urgent need, especially with schools starting up and everything. How long? I mean, I'm on a PROPS, and I know that usually takes a little bit of time, about 6 months or so for us to get that. So we're going to have to come up with the method of providing the providers who don't have those Medicaid codes that for the triage and the stabilization and the crisis intervention, how we're going to be able to keep them whole to do this. So how are we going to do that? And then I guess my next question is, if we were using ARPA dollars, I understand the dollars are until the fall, the spring of 24. So how are we going to address that in making sure that they get the funding to keep them whole? We don't want them to lose because they took a faith in this. And so I want to make sure that we figure it out. That's all.
I could give a status update, but it would
Take a
not
long
be for
time.
me to speak, to what happens from here.
Okay.
So what we've been told by DSS, and I don't want to speak for DSS, is that they think the process of getting the rates in place should be in place by the 1st of the year, by January 1st.
Fantastic.
Is their goal.
Okay.
In consultation with the providers, they've said that then the process of determining how much of that service is covered, depending upon how many clients come in through the door, how many of them are on Medicaid, et cetera, that will determine how much of the program cost can be borne by those fees. So that process, starting in January, for example, will take some time to work out. And yes, it will not be really definitively established by the time some decisions have to be made about how do we fund it from here.
Well, I thank you for that. And I guess I just want to say that we need to make sure that we provide our providers who are doing this with the support. I know the ambulances are another issue, and that's going to be something that we need to. So I guess we have a lot of things to work out in order to make sure, especially for delivery of children. I mean, and then the other question would be the hours. And when you were trying to figure out the hours, because everybody has it, and I know it's in process, but everybody kind of has a different time frame. And how we address it so it's the need as opposed to what we have, I think is something that we need to look at too, because the Yale New Haven is 24/7. But I think there's probably in Hartford and in Waterbury, I think there's going to be needs for evening hours more so, because during the day, they may end up going to the emergency room, unfortunately, until we have something to balance it off. So I would like to make sure that we talk about that very, very soon.
If
okay?
I may, contractually, each of the provider agreements indicate that they will have 24/7 availability. They are working toward that, given some of the workforce issues. Right now, most are about morning through late evening and not yet overnight, but that is the next piece. And so that is something that they will each be putting into place so that across the state, there'll be 24/7 availability.
I think that the 24/7 also is going to be connected to the amount of money that they're going to be reimbursed. Because I know that if we have somebody 24/7, they're going to need to be paid for. And so that's got to also be factored into that too. So we are, I know I'm asking a lot of, but that's what we're supposed to do for finance. So just to make sure that we want everybody to get paid, and we also want our communities to have the services. So thank you very much. And I appreciate it.
Could I just quickly add the privately insured, the uninsured, and so that we don't begin to address that. And I think your question is vital because we can't go with the current structure. It won't last very long. And we also won't have much data until October and November, which is peak season for when things really shoot up in the emergency room. So that also we don't have the data to help inform the volume of care that we need to cover.
So if I could jump in here at this time, we have about 5 more minutes and my good co-chairs both have a question. And so does Senator Seminar.
Yeah, Senator Seminar.
So if we could have Claudio, Senator Seminar, and then
And then, I'm sorry, we have Jeff and Nuccio as well.
And we may need to ask if we could have our questions forwarded to us, if just out of the respect for time.
Yeah, and you gave me a perfect segue because I didn't want to lose sight, building on good Representative Walker's point about sustainability, seeing these as services. Once they're built, we've designed them, we've done the capitalization. Fundamentally, we need to find a payer source. Medicaid is part of the equation. I'm also mindful of all of our efforts over the past 2 years where a lot of parents came in who had commercial insurance and were not getting covered and didn't have the same access. So it's great to have this service, but if the choice is between an ED that's paid for and covered by insurance and a UCC that's much more preferred but not covered by insurance, that would have to come out of pocket or some other mechanism, that's not really a choice. So I want to lift up the work that has to happen on the commercial space and invite the UCCs to also help us figure out what's the role for policymakers in that conversation to initiate commercial coverage. I know that OHS is doing a report per 5001, not this past year, but the year before, looking at payment parity and commercial insurance, and that will be part of it. But if there's other ideas, I think that's a focus area that we need to really tackle early on. Thank you.
Thank you so much, Senator Seminar.
Yes, thank you. And thank you for the very comprehensive summary of what you're doing. And obviously you're doing really great work from the entrance to the exit and beyond. And it just sounds like a beautiful setting and one that I would very, very much feel comfortable referring people to. My question, a lot of my questions were align with the questions that were already asked. And my concern is also, I represent the Northwest corner, and I know that that was touched on, but the Northwest corner consistently is forgotten and left behind in terms of availability, transportation. I can go on and on and on, but so I hope that as we continue to look at this and as a group, we continue to look at this, that we look at those areas too, and ensuring that the people there get services as well. My other question, and I was very concerned about the ARPA funding, hearing that this was funded by ARPA, and where are we going to find the funding after that? But my other question was, have you had, or as a result of the workforce shortages, have you had to turn anybody away? Is that ever happened, or do you see that happening in the future?
So I can say, fortunately, no. I mean, honestly, we have, like I said, we have very committed folks who are in this program across all of the locations. So we've had people stay 2 hours after they're supposed to be going home in order to make sure that they provide the care necessary to the families. That's the level of dedication of the staff. And obviously, as agencies, we make sure that they are paid for that time. But no, that has not happened as of yet. But again, we have to think a little bit about scalable, right? And making sure that we're able to provide the absolute best care in a short period of time, right? Because we also don't want families to be there for long periods of time and be able to meet all of the needs, but given all the constraints that we've pointed out and have been discussed.
Thank you. Thank you so much.
Thank you so much. And final word, Rep. Nuccio.
Thank you for that. I wanted to follow up on a couple of things between what Kathy and Tony had said. I had a meeting last week and have heard a lot of concern and disgruntlement around the fact that ambulances cannot bring kids to these urgent care centers. So I'm interested to find out what we can do about that. And in regard to the funding, the 4.5 million for 12 months, did that include reimbursement from Medicaid and private insurers? Was that over and above what you expect to bill and receive back from insurance?
So the funding that we put in the presentation represented only grant funding. To date, the UCC specific reimbursement is not in place. Providers, as I said, are eligible to pursue outpatient levels of reimbursement. In terms of the ambulance question, as I said, legislation provided for the process to be implemented to authorize ambulances. There are specific protocols that surround that. And so we have been working with DPH and their Emergency Medical Services Division. There are certain committees, is my understanding, that process this sort of these protocols. And so that is underway. They've actually responded back to us with some clarification questions and requests for more information. So the process is ongoing. And we are told that it should be in place sometime this fall.
Okay.
I'm sorry, Tammy.
No, go ahead.
I wanted to kind of wrap up, if I could ask you, just because it's 4 o'clock and I've held people over 30 minutes longer. Would you mind just forwarding me any other questions so that we could make sure that they are answered? And
Yeah, that's my only follow-up on that, though, was I'm just not sure I understood the 4.5 million, if that included reimbursement or if that was above and beyond reimbursement. I didn't understand the answer to that.
It was 4.2 of grant funding.
4.2 of grant funding.
Right.
So that's
include-
you'd also receive whatever you're being reimbursed.
Reimbursement would be over and above that.
Okay, so I guess I have a lot of questions about that. So Tammy, we'll have to follow up on that because
We'll definitely follow up on that.
yeah.
But thank you. Thank you so much. And I have to just thank everyone for being here, for your extra patience. This is something that is important I can see to all of us. We have so much work ahead of us, but it is wonderful to hear the start of the UCCs, and we know that we would love to have sustainability, and this is something we'll have to tackle. Thank you so much for Tao Youth Justice Center. And let me just remind you, we will be here again. It will be October 4th. We will have our meeting at 2 p.m. in the same space. And it's not my favorite space for this meeting. I would like to have circular, but because of the size of the committee, this is where we are. And if you have any other questions or anything, be sure to forward them to us. And we will definitely address those. Thank you for your time. And I'm excited. We're going to TCB. Thank you so much. Take care.